organic cause to your symptoms, and you haven't thrown anything up yet. So what actually are we talking about? Let's cut to the chase, really. If you've got patients with symptoms, as I said, those can be diarrhea, pain, bloating, constipation, nausea, weight loss, what have you, bleeding. What are we actually talking about if all the investigations to date are normal? Well, what we're actually talking about is functional gut disorder. I've already used these terms to some extent, and just to clarify, in case some of you aren't aware of the differentiation, in gastroenterology and bowel disease, we generally talk in terms of two categories of disease process: the organic illnesses and the functional ones. What's the difference? Well, organic illness is where you deploy your investigations to exclude. So you're looking for structural changes, things that are there that shouldn't be, or are there or aren't there that should be, where you have an identifiable disease process, which we understand as a disease, if you like. That can be macro or microscopic, biochemical, structural, it doesn't matter. Examples are cancers, polyps, hemorrhoids, gallstones, diverticular disease, infectious causes, inflammatory causes, Crohn's disease, things like that. That's all organic, from the trivial to obviously the serious. Functional gut disorder, it is where patients present with very similar sets of symptoms, but when we investigate them, we can't find a cause. Everything looks ostensibly normal, whether it's a scope or scan or what have you. Now, the less charitable person would say, well, we term something a functional disease when we don't know what the hell's going on. And to some extent, that is true. And it may well be that in 20 years' time, there is no such thing as functional gut disorder, because we've worked it out, the neurophysiology or the biochemistry of it. But to say we don't have any understanding of it is a little unfair, as we'll come on to in a minute when we talk about some of the facts about functional gut disorder. So where does functional bowel disorder fit in to the whole scheme of things? Well, the most famous functional bowel disorder is clearly irritable bowel syndrome, which I'm sure you've all heard of. And that can be classified into three main subsections: irritable bowel syndrome, predominantly constipated; irritable bowel syndrome, predominantly diarrhea, that's IBS-C and IBS-D on the Venn diagram there in the middle. And then in the middle of that, you've got IBS-M, and they are the most difficult people to treat because their bowels are all over the place. They are erratic, to say the least. So they have days of constipation where they don't go or strain, and then they have days of diarrhea and frequent loose stools. Having said that, around the periphery, we've also got the other functional conditions: functional constipation, functional bloating, and functional diarrhea. Now, here's the thing. Irritable bowel syndrome is often overdiagnosed. And whilst not wishing to be accused of being pedantic, to have irritable bowel syndrome, you've got to have pain. So if you haven't got pain, you've not got IBS. Fact. So you don't want to call it that. Having said that, you can get functional constipation without pain, functional diarrhea, or functional bloating without pain, which is then called exactly that: functional diarrhea, functional bloating, functional constipation. And they all require slightly different approaches to management. There is the functional disease can affect the whole of the bowel, not the whole of the gut, from the mouth to the anus, not just the large bowel and small bowel, which is predominantly what we're talking about today. So you can get esophageal disorders, you can get functional dysphagia where you can't swallow, but there's no cancer stopping you from swallowing. The esophagus just isn't working as well. It goes into spasm, or isn't functioning properly. Gastroduodenal disorders, so you can get gastric outlet obstruction, where there is no obvious organic cause. Biliary disorders, there's one famous biliary disorder called SOD, aptly named, SOD. It stands for sphincter body dysfunction syndrome. That's where the actual sphincter at the bottom of the bile duct goes into spasm and can mimic gallstone pain. You've got belching disorders and vomiting disorders. Less said about those, the better. And then you have anorectal disorders. Again, you get various pain disorders in the rectum, which are called, there's two most common: proctalgia fugax and levator-Raynaud syndrome. Proctalgia fugax, some of you probably would have experienced it. It's where you're walking along, minding your own business, and suddenly, out of the blue, you get this intense anal pain. for a few seconds and it disappears. My wife calls it shooty arse pain. I think that's probably quite aptly named. Just looking at the irritable bowel syndrome, some of the history of it. It was first described and properly diagnosed by Manning. I include this slide specifically so you can look at some of the symptoms you might be dealing with in patients with IBS. Again, pain being the predominant symptom. Looser stools with the onset of pain. We now also say you can get constipation. It's a change in bowel habit. More frequent stools, bloating, passage of mucus, and also a sensation of incomplete evacuation. Manning called that rectal dissatisfaction. Now the diagnosis is more advanced. We have the Rome criteria for diagnosis, and since then, NICE have got involved, the National Institute for Clinical Health and Excellence. Rome is probably more of a scientific diagnosis, but NICE is probably the one that you ought to go by. And again, what you're looking for these symptoms just to reaffirm once again that you are dealing with IBS or functional gut disorder, functional bowel disorder, rather than something more sinister or something organic, which may need investigating. So what NICE says, if you've got abdominal pain or discomfort that is relieved or made worse by defecation now, okay, but it changes with defecation, or is associated with altered bowel frequency or form. So it doesn't really matter which way it goes, diarrhea or constipation, loose or solid, it has to change with the pain. And two of the following, straining urgency, incomplete evacuation, abdominal bloating, and symptoms made worse by eating, and the passage of mucus. And that's the criteria most GPs would go on to diagnose functional bowel disorder or IBS. I think part of managing these patients is knowing when to worry. When should you get concerned? Because as I said to you before, you're going to get some patients who've come to you and they've been fully investigated. And we know we're absolutely pretty sure there's no organic basis to their symptoms, specifically no sinister organic basis to their symptoms like a cancer or ulcerative colitis or Crohn's disease or whatever. And that you don't probably have to worry too much about them. But it's the ones that are coming to you who perhaps haven't had any investigations, and there will be some of those patients, and it's quite reasonable to make the diagnosis of functional bowel disorder without investigating the patients. But if you see these patients, when are you going to think, well, hang on a second, I'm not so sure about this, perhaps we ought to send them in for some diagnostic tests or at least do some blood tests? Well, I would argue that list there is a pretty good one, a pretty good rule of thumb. So unintentional and unexplained weight loss, that's a pretty classic one. Rectal bleeding, you've always got to be a bit careful of rectal bleeding, particularly in the over 55s. A strong family history of bowel or ovarian cancer. So if you've got more than 3 members of the family with either of those 2 cancers, particularly if any of them were under 55 and a first degree relative, it might make you think twice. People aged over 60 with a change of bowel habit lasting more than 6 weeks with looser or more frequent stools. That's taken directly out of the fast-track 2-week colorectal referral criteria, actually. And again, it's something you might want to think about in that age group. Anemia, really important. You never get anemic with irritable bowel syndrome or functional gut disorder. So that is when you need to think about referring on. Again, this isn't rocket science. You feel the tummy and there's a big lump there. Obviously, you've got to get that looked at. The same with doing a rectal examination with a finger. Some of you may do them, some of you may not, I don't know. But if you're used to doing them and you feel an unusual mass, again, that's something you might want to speak to your general practice about or refer in. Inflammatory markers, either in the bowel or in the blood, again, you might want to refer in. And also, if you've tried quite hard to get on top of the symptoms, but they're just not, you're not making any inroads, you might want to think about some diagnostic tests. British Society of Gastroenterology look at it a slightly different way, but again, this is quite a good rule of thumb, a bit simpler, but it kind of draws everything together and adds everything together. So anyone over the age of 45 with new symptoms, that's a slight red flag. Recent symptoms, obviously, if someone comes along and said, look, I've been fine all my life, 6 weeks ago I started to get a bit of bleeding, a bit of tummy pain, my bowel habit has changed, is very different to someone who says, oh, it's been going for 20 years, and it hasn't changed. So they've selected themselves out of having a serious illness, clearly. But if it's a recent onset, you need to be more concerned. Again, progressive symptoms as opposed to intermittent or fluctuating symptoms are more likely to represent something organic or more serious. If you've got any of the symptoms which we've discussed in the previous slide, we call them sinister features of NICE, then again, you need to be a bit more on guard. And from the opposite side, if you've got all the functional symptoms, as I described in the Manning slide or the NICE slide, then if they're absent, you're more to worry. And if they're present, you're going to worry less, if that hopefully makes some sense. And then if you are going to refer, you need to decide whether you're going to refer by the 2-week referral fast track clinic or go via the GP for those physician associates, or refer in on a more routine basis. So let's look at. I'm not this. This is a talk which I've strongly adapted from a GP talk. So some of this I'm going to quickly skip over, but there are some background bits of information you may find useful when talking about functional gut disorder and IBS. Well, I said at the beginning of the talk, the slightly less charitable people would argue that we call something functional or irritable when we don't really know what's going on. But we do understand some of it, and we're starting to understand the really important relationship between the gut and the brain. We call that the gut-brain axis. We know that there is a brain of the gut called the myenteric plexus. It communicates with the brain all the time through various neural pathways, most of them the autonomic nervous system. So that's a parasympathetic vagus nerve, and also the sympathetic system. And most of this is housekeeping. It goes on day to day without you knowing anything about it. Information coming back from the gut, information going back down from the brain to the gut, instructions, if you like. And we know that when this goes wrong, then we get problems and symptoms occur. But of course, you can't pick this up on a scope or a scan. One thing I do want to dispel is that irritable bowel syndrome and functional gut disorder is not a psychosomatic or a psychological illness. It is a disease of the gut. And I think sometimes when you label someone with functional gut disorder or IBS, this is one of the things about managing them, you've got to make it very clear to them that you don't think that they are a psychiatric case or a psychological case. That said, we do know that stress and anxiety can trigger symptoms in about 30% of people. We also know that 50% of people who develop these functional symptoms can link it to a life event. And also there's quite a high use of incidence of childhood sexual and physical abuse in about 30% of patients, but it's still not a psychological illness. I'm going to skip that one. So we've talked about, we know about the gut-brain axis. This is what we do understand. So the autonomic nervous system, we know, and we've studied in the body changes in autonomic nervous system in patients with functional gut disorder and IBS. Okay, we've also managed to measure motility of the gut, and this is different. I'm not going to go into all the ins and outs here, but we just know in IBS patients and functional gut disorder, there is a different gut motility to so-called normal subjects. Visceral hypersensitivity, again, this is very important in IBS, particularly where you have pain. Again, we know, but we don't know exactly how, but we do know that the bowel becomes oversensitive to pain. So you may eat something, the bowels are just working normally, but they're triggering pain responses, which are then obviously interpreted as pain by the brain. And we know that pain is handled through different pathways in people with IBS. We know some quite interesting from some quite interesting studies where people have shoved balloons up people's bottoms and blown them up. I won't go into the actual ins and outs of that, but if you want me to explain that very interesting study, I can do at the end. Diet, again, we know is a big trigger and for symptoms, or can be, and forms quite a large part of how we manage these patients. We've all heard of the good and bad bacteria, the microbiota, the microbiome of the gut. I'm sure you've all heard of that. Having said that, it's much more nuanced than that. We have trillions of species, or billions certainly, of species of bacteria living in our gut, and for the most part they do us a great favour in helping us handle food and waste products. But even slight changes in bowel flora, even if they're all still good bacteria, can change the way food is handled and can alter symptoms, whether again that be bloating or diarrhea. I'm going to skip bile salt malabsorption and genetics and immune inflammation. Let's move on to some management things now and treatment. So I'll show you this slide because it's a busy slide and it's very sort of involved. But what I want to show you from this is the holistic nature, essentially, that you need to approach management with functional gut disorder, because basically it is a systemic illness and therefore requires that approach to treatment. Okay, so let's talk about some of the management things. How are you going to approach these patients? The first thing is explanation, education, and general advice. I think that is so important because a lot of these patients are anxious that they're harbouring serious illness. You tell them that you've got IBS or functional gut disorder, the first thing they will think is you're trivialising their illness, which you obviously are not, and you mustn't do, because symptoms from IBS can be very severe. But I find these two sources really useful. Now, I need to change the slide because the website there, Core, you'll see that isn't Core anymore. It's called rather irritatingly Guts UK. So you can Google Guts UK and you can go to that website. It is the Digestive Diseases Foundation website, and there is loads of information there, all things gut related, but particularly a lot of stuff on food and diet and IBS and functional gut disorder. And it's a really trusted source of information that you can send patients to have a read about. The other one is the BMA book, Irritable Bowel Syndrome, which is there. Again, you can get that from most pharmacies. And again, it's a little pamphlet book. It's pretty cheap, but it's got some really good information in there. Again, we can look at psychological therapies to treating IBS. Now, once again, I want to iterate, it's not a psychological disease, but we do know that in patients where stress is a trigger or anxiety is a trigger, they do respond very well to certain psychological therapies such as cognitive behavioral therapy and the like. We can look at the diet. There's a big area of input there. And then we can look at drugs and pharmacology. And I think some of you at least can prescribe. I'm not sure whether you have limited prescribing ability or whether you can prescribe some of the more advanced drugs. Again, we can quickly look at that later. And then we've got alternative therapies, which I'm not going to dwell on too much. So let's look at the diet. Right, general advice. What do you give to patients with symptoms? It does depend a little bit on their symptoms. Again, the predominant ones, again, are stress, constipation, diarrhea, pain, bloating. Those are the four main ones. You might want to ask them to keep a diary of their food intake. It's quite a big thing to do, because if you think about it, they've got to make an entry into the diary every time something passes their lips, whether it's solid or liquid. But sometimes, if they are motivated enough to do it, you will pick up some patterns, and you might be able to pick out some aspects of their diet which is more likely to be causing them trouble. Regular meals. I know our parents always used to tell us this. I'm not talking about grazing. I wouldn't recommend a grazing attitude towards diet. Most people who do that eat little and often put on weight. But what you don't want patients doing is going for long periods without eating and then eating a big meal. It's something which I have to admit I am guilty of doing, particularly at work. I'll go throughout the day, eat very little, and I have a big meal at night. So going for long periods of starvation, big meal, if you are susceptible to functional symptoms, that is more likely to trigger them. Water, we don't we don't drink enough water. None of us do, if we're being honest. So water's a very important constituent of our diet. It keeps bowels healthy and also reduces constipation. Resistant starches, again, these are more prolific than you think. I don't know if you've ever heard of resistant starches, but basically these are substances which occur in food that we eat. Now, they generally tend to occur in starchy foods like pasta, complex starches like pasta and potato. When you cook the product, cool it, and then reheat it. Now, you may ask, well, when do we do that? Well, actually quite a lot. Resistant starches form in a lot of cooked chill foods, even expensive ones from Marks and Spencer's and Waitrose, because you are cooling, reheating. Lasagna, classic example, where you may boil the pasta first, cool it, and then bake it. Pies, things like that, have resistant starches. And the resistant starches are basically where the starch molecules form cross-links. They can't be broken down in the gut by the usual enzymatic processes. They reach the large bowel. The bacteria in your large bowel have a field day with them and cause windy symptoms and pain and the like. So the good side of resistant starches, you're in effect increasing the fiber in your diet, and the more you cool and heat and cool pasta, the more the calorie content goes down. Something some of you may have known about. Artificial sweeteners, finally, polyols, things like that. They're in a lot of things that we drink and eat. They can also cause symptoms, so they are best avoided. Fiber, here's a big one. In the old days,
Mr Stellakis, I have a question for you.
Oh, yeah.
Sorry to interrupt. I think you might be coming on to this shortly. Would you recommend the low FODMAP diet for IBS?
I'm coming on to that.
Thought you might be.
That's fine. So fiber, I'm keeping the best till last. So fiber. In the old days, we used to just tell people to eat more fiber. Now, that clearly is not the best advice for someone who's got diarrhea or windy symptoms. It is probably a good thing to encourage increased fiber intake in people who have constipation or IBS subtype C, and you can do that in many different ways. But in people with IBS subtype D, it's probably better to try and reduce some of the fiber intake, particularly if they're having a lot of fiber. Two types of fiber, soluble, insoluble. You may know about this. Soluble is brassicas, oats, barley. That fiber dissolves to some extent in the gut. It doesn't tend to bloat you, but can make you very windy. Insoluble fiber is roughage, basically. It's wheat, wholemeal, wheat germ, pip skins, nuts and things like that. Doesn't tend to make you break wind too much or flatulent, but it can make you a little bit bloated. Again, a combination of the two is generally advised. And I put oats there because oats, of course, is the champion of breakfast of champions. Moving on to exclusion diets, we can talk about this a bit. If you exclusion diets, chopping out large swathes of someone's diet and then reintroducing it can be quite instructive, but it's probably better done through a dietitian. And there's a new vogue to doing IgG studies. I wouldn't necessarily go down that route to see which ones you're going to cut out first. That's a little bit of hocus pocus. But certainly you can look at various aspects of the diet, include smaller aspects and reintroduce and see if that helps. Now, if you're going to do that, you need to do it for about 3 to 4 weeks. So if you're going to cut out something, and we'll look at some of the things you can do with that later on, you need to do it for 3 to 4 weeks, then reintroduce it and see if there's a difference. The most common intolerances, before we get onto FODMAPs, and I will get there, I promise, are lactose and wheat. Okay, and if you are going to cut something out, that is probably where you would start, but one at a time. Now, lactose is interesting. Lactose, of course, is the sugar in milk. In fact, it's true to say the human condition, as we get older, we lose lactase, which is the enzyme to break down lactose, to the point where the vast majority of the human population worldwide are lactase deficient and therefore lactose intolerant due to that deficiency. Obviously, infants have to be not lactose intolerant, and there's a real problem if they are. But as we get older, we become more intolerant. It's only the Northern Europeans and Northern Americans that seem to have retained their ability to digest lactose. Whereas, as you know, the argument is you don't get much on a traditional Chinese or Japanese or Korean menu. You don't get much milk. You don't get much dairy. Lactose, when it's not broken down by lactase, actually becomes a FODMAP, which is a fermentable disaccharide, which is then can cause problems when it reaches the large bowel. Wheat, gluten, the Gleiden fraction of wheat is another common intolerance. Don't get confused with celiac disease, where someone has an allergy to wheat. That is a very, very different situation. That would be definitely an organic illness, and wheat abstinence has to be the absolute there. With intolerance to wheat, like with anything you're intolerant to, you can still eat it with impunity. It's not going to harm you, but it may just cause symptoms. So sometimes you have to debunk that difference between wheat intolerance and wheat allergy with the patient. One good way of testing for milk for dairy intolerance is you can do lactose, hydrogen breath tests and all the rest of it, but actually just get them to drink a pint of milk. And if it causes symptoms, they've probably got a degree of lactose intolerance. FODMAPs, here we are. FODMAPs came in. It was an Australian, I think the Australians were first to introduce this as a concept some years ago now. FODMAP stands for fermentable oligodisacharide, monosaccharide and polyols. Essentially, to cut a long story short, sugars in the foods that we eat, which are broken down by the bacteria in our gut, causing flatulence, diarrhea, wind, pain, etc. There is some debate about what foods contain more FODMAPs, what less. There are even apps you can get for your iPhone now, and there are much more exhaustive lists than the one that I've posted there. But that's a start of a 10. It's quite pretty, if you like. And it says there, eliminate foods containing FODMAPs. Once again, I want to stress it's not about eliminating foods, because FODMAPs often occur in some of the really good foods, the nutritious foods that we eat. So cutting them out altogether, at least long term, is probably not a good idea, but certainly being mindful of the higher FODMAP foods is a good thing, and reducing some of the higher value FODMAP foods it may be worth a try to see if you can reduce some of their symptoms. As I say, that is not an exhaustive list. You can get it off the internet. There are apps on the internet now which give you a much more definitive list. But if you're going to reduce FODMAP load, then do it again for 4 weeks or so. And then if you've had a good response to that, you then can start reintroducing the foods that the patient misses the most from the high FODMAP group, and see if and when symptoms return. And that's how you kind of manage it. Trigger foods. There are trigger foods that don't fit into any particular type of category. There is a theory that these foods, because they are what I call pleasure foods, actually cause a secretion of 5-HT or serotonin, the happy neurotransmitter, if you like, and that can have effects on the gut. Now, you've all heard of SSRIs to treat depression, serotonin uptake inhibitors, because serotonin receptors are in the brain and they get downregulated in depression. I'll tell you something, the vast majority of the body's receptors, serotonin receptors, are actually in the gut. There's far more in the gut than there are in the brain. So the theory is that if you're drinking foods which give you pleasure, they then go on to give you symptoms. It's the cosmic karma balance, I'm afraid, taking pleasure from tomorrow and bringing it forward. But again, they're not doing any harm, but they may trigger symptoms. So, and those are a classic list. So wine, caffeine, eggs, spices, onions, and of course chocolate. With diet, particularly for a month, I always recommend, nearly always recommend the taking of probiotics. There are many out there. The ones I always use are VSL-3. They are the industry standard. You can buy them online. They're not cheap. They're about £45 for a month, and they taste dreadful. They taste like cold dilute porridge with slightly off whey cheese, but you need to just gulp them down. And warn patients of the taste. But they have, I mean, most probiotics have between, I don't know, 3 and 4 million colony forming units. Some of the better ones have, a couple of billion colony forming units. VSL-3 have 400 billion colony forming units. And that's the kind of dose you need to make an effect in the gut. Nutritional therapy, I'm not dwelling on today. Let's look at some of the pharmacological things that you can do then. Now, some of these I'll mention, I know some of you can prescribe, but some of these you can buy over the counter and might be worth a try. And it depends a little bit again on the symptoms. So for abdominal pain and bloating, some of the bowel calmers or antispasmodics are worth a try. Mebevrin or Colofat, you can buy it over the counter. It's cheaper on prescription, obviously. That is quite good if people have pain and diarrhea. It tends to slow the bowel down a little bit. Alvarin citrate, also known as Ordimol or Spasmanol, again is quite good for pain. If people are getting pain, particularly after eating or with bloating. Buscopan, I don't tend to use Buscopan that much. Again, it can be brought over the counter. It tends to dry your mouth out, and I don't think it works particularly well. It's a smooth muscle relaxant. Peppermint oil and Colpamine, again, can be quite good. And sometimes you might want to try patients on silicol, which is an absorbent you can buy over the internet, or charcoal. Again, an old-fashioned remedy, helps quite a lot with flatulence and bloating. If you're going to suggest charcoal, they need to be taking 1 to 2 grams with each meal, not milligrams. So you can buy it in 200-300 milligram doses. A waste of time. It's got to be 1 to 2 grams. If those fail, then there are proper drugs that you can go on, particularly neuropathic pain killers like tricyclics, amitriptyline, imipramine. You might want to use an SSRI sometimes in patients, particularly if there's an anxiety issue as well. And then gabapentin and pregabalin, again, neuropathic painkillers. I would not advise those because we now know that they have quite a potential for dependency. So you have to be very careful there. Diarrhea. How do you treat diarrhea? Well, again, loperamide, Imodium. It's over the counter. It's perfectly safe. As long as you don't constipate the patient and as long as you're not masking something that you should be referring. But again, I take you back to those times, when to worry. But certainly for short periods of time or when you know that they have functional diarrhea, loperamide and Imodium, they're perfectly good. You can get it in tablet and syrup form. Syrup is actually easier to titrate smaller aliquots and doses. The tablets are 2 milligrams a pop. The syrup is 1 milligram per 5 mils, so you can give half a milligram, 1 milligram, etc. Codeine, it's good at clearing up diarrhea. I would not advise it because again of the addiction potential. Cholecystyrene and colosalivam, they are bile salt sequestrants. Again, we tend to use those once we've confirmed bile salt or bile acid malabsorption. So talk for another day, really. Again, I don't want to dwell too much on the second list there. Those tend to be only used by secondary care specialists like me and gastroenterologists for retracted diarrhea, which is not responding to simple measures. Constipation, windy symptoms, again, lactulose, again, buy it over the counter. I hate lactulose. I think it's a dreadful thing. It very rarely works well. Occasionally you get the odd person who loves it. It just makes you fart, quite frankly, and doesn't really loosen the bowel or help constipation. If you're going to give an osmotic laxative, you're much better off giving something like Movicol, Cosmocol, Laxido, that kind of stuff, which again, I think you can buy over the counter. Fiber gel you can buy over the counter. Again, it's good to try. It's a fiber supplement. It's not Physidium husk, is it? It's Spigula husk. Malox and Malox Plus, again, another osmotic laxative you can buy over the counter. Deflutine and Windies, they're basically simeticone compounds, which the same stuff as an Infracol, basically. It's a surfactant. It breaks up bubbles in the bowel and is supposed to help with windy symptoms. And I think it does to a certain extent. And again, things like precalopride, linaclotide, tenanopor, and lubiprostrone, those are second and third generation prokinetics, which are really generally only started again by specialists. So psychological therapies, again, think about this, very difficult to get on the NHS, and I'm fully aware of that. If patients, are prepared to, fork out 50, 60 pounds for a session, it may well help them an awful lot. Waiting for CBT or dynamic psychotherapy on the National Health at the moment, you'll be waiting an age. But in selected patients, and I say you have to select your patients for this, they do respond very well to those therapies. But you have to have someone who is engaged with the process. and who actually wants to do it. There's no point taking a patient there who has no belief in it or doesn't want it, because I can guarantee it won't work. Hypnotherapy, again, can work in certain people. Biofeedback, SNS, and support groups. Support groups, again, there aren't many for functional gut disorder. I don't know why. You'd think there were. But that's something you might want to consider starting if you've got a number of patients. Bringing them together and discussing their symptoms, and people talking about their problems is always good. I'm going to leave biofeedback and SNS, but that's a bit more specialised. I'll just very quickly on alternative treatments, acupuncture again. I don't have a lot of experience with this. I have had patients go off to get acupuncture. Generally, what happens is it works for a bit and then it stops. There are herbal medicines, some Chinese herbal medicine. You can try Ibrogast. I've tried once with rather unencouraging results. But again, there are things out there. The problem here, I suppose I include this slide because if you've got someone who's becoming desperate with their symptoms and you're not making any headway, and everything you try just isn't working, they are quite vulnerable, some of these patients, and they are prone to going off on the internet and spending huge amounts of money having tests, quite frankly, which are totally irrelevant. A lot of the immune tests and IgG and IgM and IgA tests, what these companies do, they mix it up with pseudoscience and science, charge them £1,000 and write a report, quite frankly, which is buff. And so to some extent, you have to be mindful of that and protect your patients. And also, there's a lot of people there selling snake oil out there. So I think if you're really struggling with functional symptoms, then you speak to your GP and consider getting a specialist opinion. Just a quick thing for the future. There's a lot of research now going on to IBS. It was always a Cinderella subject because it doesn't kill you. And no one really, it wasn't sexy. If the disease doesn't, I mean, we all go into medicine to cure people, save people's lives and cure cancer, don't we? Cancer's sexy in that respect. IBS isn't. But what the pharma companies have recognized, that IBS actually affects a very specific demographic, i.e. high achievers, wealthy, westernized cultures, goal-driven, etc. So there's money to be made by coming up with diagnostic tests and treatments. So this has spurred on a huge amount of research. This is some of the ways we're starting to understand the gut-brain axis side of things. There are potential diagnostic tests, so that would be good, wouldn't it? You come in and you actually have a diagnostic test and say, yes, you've got IBS. We don't have to worry about anything else. So there are markers, people looking at markers for that. And a lot of the new treatments, again, are aimed at all the aspects of IBS, from the neurophysiology of it to the gut part of it, receptor antagonist and agonist treatments, etc. That's it. So I'm going to stop there. That was the original last slide, which I always include for any questions, but it shows you when I've updated this talk many times. So that's when I first did it. So I include a slightly updated version of that. I don't know if that appeals anymore, but I will end there and ask if any of you have got any questions at all.
Please type them into the chat function, or just take yourselves off mute and pop your hand up if you have any questions. Gone very quiet. You've stunned them into silence, Mr. Stellakis.
Oh dear.
No, we have two questions. Linda, do you want to go first?
Oh, hi, can you hear me?
Yeah.
Yes.
Hi, sorry, I couldn't find the chat box. I've come across two patients recently that have been diagnosed with SIBO, and I've never heard of it before. What would make you think of that? What would make you suspect that they have SIBO?
Okay, so SIBO is an interesting one, and it is the de rigueur diagnosis at the moment, and this is slightly bordering on the snake oil salesman, I'm afraid. Now, I do send people off for SIBO testing, but only to very respected laboratories. SIBO stands for small intestinal bacterial overgrowth, and it does exist. It's not a bogus concept, but it generally only tends to exist in certain situations, particularly the elderly, or where people have had major gut resections or major anatomical surgery to their gut to rearrange the anatomy of their gut. So they have blind ending loops and things like that. Then they get bacterial overgrowth. A lot of people send themselves off to get these hydrogen and methane breath tests, and that's how it's diagnosed. And there are European and American guidelines on what level, you know, if you're looking at the methane and hydrogen breath test, what integer, what level do you call this SIBO or not? Because it's a gradual integer which goes up. Now the American framework or reference is a lot lower than the European one, which I think should tell you something. The European reference is higher, so you have to, the threshold for diagnosing it is higher in the European reference guidelines than the American ones. If you've got it, if you truly have got it, if you've got evidence of it from a reputable laboratory, and they've done lactulose, hydrogen and methane breath testing, both have to be done, and it's positive, then there is an argument for trialing them on antibiotics for 2 to 4 weeks. The antibiotic of choice is rifaximin, which is an antibiotic, broad spectrum antibiotic, which stays in the gut. The problem is it is monumentally expensive, and I think it's quite difficult to get it prescribed on the NHS. I think it ends up being about £900 for the 4 weeks. It's almost £1,000, I think. So what a lot of specialists do is prescribe a combination of neomycin and metronidazole, which probably isn't as good, but does tackle that so-called overgrowth in the small bowel. What you will find if you've got someone with SIBO rightly diagnosed or wrongly, and you prescribe rifaximin or antibiotics, you often do see an improvement. And then when you stop the antibiotics, after a while, it comes back again. So what do you do then? It is a difficult question now. Does that answer your? Can I ask you how old these patients were, and have they had any abdominal surgery?
Yeah, no, they're both young because I work at a university practice.
Yeah.
And the one that's kind of in my memory at the moment, who I only saw last week, she had a long-standing history of nausea,
Right.
nausea. Had been going on for 2 years. And
Yeah.
she's just registered with us recently. She's from Southampton, and her diagnosis was made by a gastroenterologist there.
Okay.
And she's already had 2 courses of rifaximin.
Yeah.
The first course seemed to help her.
Yeah.
And she had another course in December.
Yeah.
I think it was only a week that she was given, but she said it's made no difference. And so
Usually
she's back saying, I've got more symptoms.
Yeah. I mean, if you Google, I have a lot of young, it's funny actually, it's young patients. And that, again, I think this should tell us something because they are much more internet and web savvy. If you Google symptoms of IBS and stuff, the first lines on a Google search will all be companies or sites telling you about SIBO. And I have lots of young patients come to me and say, I've got SIBO. And I can guarantee the vast majority of them haven't. It's a difficult thing to deconstruct. I'm not suggesting your patient hasn't, if they've been diagnosed by a gastroenterologist, but it's a difficult, if someone's convinced they've got it, it's quite a difficult thing to deconstruct. And I say it's difficult to treat. What do you do? I mean, the only thing you could try is a combination of metronidazole and neomycin, and see if that works better. But you're going to soon run out of options, and then you're back to square one again. Have you tried probiotics?
She did send us the list of antibiotics that we could go on and try, but there was no kind of duration or dose. It was just saying you could try this, you could try that, and it's like, well, what interval and for how long?
So mostly, I would say rifaximin. I don't think there's any point prescribing it for a week. I mean, the shortest duration I would say was two weeks, but really, it's 4 weeks. Is I think it's 600 milligrams TDS for 4 weeks or thereabouts. So you need to be on it for a bit longer. I think people are frightened of it because it's so expensive. I mean, this antibiotic was actually developed, believe it or not, for hepatic encephalopathy. So when people used to have big GI bleeds due to liver failure, they used to give they used to become encephalopathic because of the blood meal, and then because of the bacteria acting on the blood meal and causing an amine crisis, and rifaximin actually reduces that. So it's kind of found a slightly new use for itself.
Is there any role for the dietitian in there?
Yes. I actually, that's something I forgot to mention. I mean, I used to do a lot of my dietetic advice because I think, like all of us, there are dietitians who have an interest in it, and there are dietitians who haven't. And you have to engage with a dietitian who's got a proper interest in functional gut disorder and IBS. And I hadn't found one actually. So I tended to do all my dietetic advice, which was probably a bit Mickey Mouse, a bit schoolboyish. But now I've found Yvonne McKenzie, who's on our team. She is absolutely brilliant. So if you find a good dietitian who has an interest and isn't just going to go and tell the patient to eat more fibre, and actually look at taking them through those exclusion diets, which takes time, they're worth their weight in gold. Really worth their weight in gold.
That's great, thank you.
And just to add to that, Yvonne McKenzie does work here at
good plug.
Warwickshire. Just quick plug there. Monica, you've been very patiently waiting with your hand up, and I have also seen that we have a question in the chat, but do you want to go first, Monica?
Yes, hello. Yeah, I'm Monica. I'm the physician associate at Bidford Health Centre. I think I just have a bit of a just a general sort of comment, I suppose, that patients, when they come to see us and they have got the classical symptoms of IBS, and maybe previously they were told that possibly it is IBS, they just think that they are a little bit fobbed off if I just say, I think I've got IBS. And I just found myself over the last 3 years working as a PA, basically just reassuring them and sort of agreeing with them, and basically saying, look, IBS is a diagnosis of exclusion. And what I tend to do is do a routine blood test, do the TTG, do the celiac screen, do the full blood count, check the ferritin levels, and so on. And if there are no red flags, and if the bloods are okay, they seem to be sort of happier with the diagnosis, because I have taken them seriously.
You've absolutely hit the nail on the head. And as you may remember, when I said to them, when you tell patients that diagnosis, particularly if you've decided not to send them in for more advanced investigations, you mustn't trivialize it, because you're quite right. Their assumption, oh, just fobbing me off. But I would argue that it's not necessarily diagnosis of exclusion. It can be a positive diagnosis based on the criteria which we've discussed. But they often will think, they'll think one of two things. One, you're telling me my symptoms are all in my mind. Yeah, I often get told that, or because they've read IBS it's all in the mind, a psychological illness, isn't it? So that's the first thing you deconstruct and debunk. And the second thing is to say to them, look, IBS sufferers' symptoms can be just as severe, if not more severe, than people with cancer, than people with Crohn's disease. I mean, I've got IBS sufferers who are basically housebound. And to tell them it can be very, and people are taking you seriously. There are things that can be done, but it takes time and effort. But you're quite right. Listening to the patient is so important. This is, I don't know if any of you are fans of homeopathy out there, but a lot of the studies in homeopathy have actually found that one of the biggest benefits of homeopathy, because I don't believe in the actual process of it, is they sit down for an hour and they just listen to the patient. They listen to the patient's concerns. They have a constructive conversation, and it makes a huge difference. It makes a massive difference. So I couldn't agree with you more.
And I also found quite a good response to amitriptyline. Once people have tried the antispasmodics, and that hadn't really worked, giving them amitriptyline, and if that doesn't make them feel like zombies the following day, that makes such a difference.
I found amitriptyline is funny, but it's not always the best tricyclic, but it's the one I always use first off. The zombification tends to wear off, so I do warn them that it should only last a week or two. I find it's very good for pain that you can't otherwise treat. It's good for some other things as well, and also particularly if they got nocturnal pain. And pain that's stopping them sleeping. That's a slight red flag. So you need to be a bit careful there. But if they're getting pain at night, it helps them sleep. Just be mindful, it can make constipation worse. So sometimes if you've got constipation and you're wanting to deploy a neuropathic painkiller, then sometimes an SSRI might be a better bet. But yeah, I agree with you. Amitriptyline I use quite a lot, and with good results.
Yeah, because just a last one, the amitriptyline, would you say just take it maybe for a week or two and see how you get on?
No,
Or
I would no longer. So basically I prescribe them. I start with 10 milligrams Noctate, and if after 2 weeks there's no improvement, I go up to 20 milligrams, and then go up to 30 milligrams 2 weeks later if there's still no improvement. I don't tend to go much above 30 milligrams. I know some people go up to 60. I think that's getting to more of an antidepressant dose there. But I would keep them on it for 3 months, but warn them that if they're getting drowsiness in the morning, it generally wears off after 2 weeks. If it hasn't, you may need to reconsider the whole thing. But I would keep them on as a minimum 3 months and then revisit.
Oh, that's very useful. Yeah, thank you very much for that.
No worries.
Thank you.
Thanks, Monica. A couple of questions on the chat. Are probiotics denatured by the stomach acid?
Yes, most of them don't make it to your bowel. Yeah. The vast majority will die and be killed before they get to your bowel. That's why it's so important to take such a high dose. I mean, what annoys me when you see Yakult and Actimel adverts saying scientifically proven, I can guarantee the vast majority of those bugs will never make it to the bowel where they need to be, the large bowel, because they're just not in high enough dose. So, you know, I don't know what the dose in Yakult is, but I think it's about a couple of million. Compare that to 400 billion colony forming units. That's the difference. And that's the kind of dose that you need to make sure that some at least get to the large bowel and then start to divide and maintain.
Thank you. Would you check fecal protectin for all patients with bowel change and abdo pain? Does a normal fecal protectin most likely mean it's IBS?
God, okay, so that's quite a complex one. Yes, okay, the first bit to that question is quite easy. If someone presents with diarrhea, proper diarrhea, and you know, and people mean different things by diarrhea, but increased stool volume with a decrease in stool consistency and an increase in frequency, I would always do a fecal calprotectin, with or without pain, but particularly with pain. Yes, I'd always do an FCP. If the FCP is normal, does it mean it's IBS? Well, it raises the suspicion that it's IBS. It makes it less likely, well, certainly makes it a lot less likely to be an organic inflammatory disorder, but it doesn't mean that it is IBS. It doesn't prove the condition of IBS.
Thank you. Next question. Is it advisable to take more tablets than is indicated for probiotics?
I don't have that problem because the only ones I recommend generally are VSL3, and if you take the standard dose, if they're going to work, they will work. So I suppose what you're asking is, I mean, what, you know, are there cheaper probiotics where if you take enough of them, you would be taking the same dose as VSL3? I don't know the answer to that question, to be honest. I suppose it goes slightly against the grain, taking anything more than what the manufacturer would recommend. So I'd probably say no to that. But if you want high dose probiotics, VSL-3 is your one. I don't know if that answered the question or not.
I can see somebody's typing, so I will wait to see what the next question is. I know we have now got to 1:30, so I'm not sure whether most people need to jump off. Okay, here's the question. What is the role of fecal calprotectin in pediatric disease, and how often is this checked?
So again, I have to say I'm not a paediatrician, so I don't deal with anyone under the age of 16, and particularly more at almost 18 actually. So I'm sorry to have to say you've got me on that one. I'm stumped. I don't know what the role of FCP is in paediatrics. I presume it's similar to adults because it's the same mechanism. So I don't know is the honest answer, and I apologise for that.
Well, that seems to be all the questions. So unless anybody has anything else, I'd just like to say thank you all for joining us today, and thank you, Mr Stellakis, for giving up your time. We will send out the recording and details of the next meeting when we've got one sorted. So thank you all.
Thank you very much. Thank you all for coming.
Bye-bye.
Thank you.